the beautiful presentation. As you see, we go from molecular biology and cellular biology to clinical medicine. And now, even more to the bedside, we hope that Marco Ranieri, now in Torino, is going to talk about clinical interventions to avoid ventilator-induced lung injury and barotrauma. He needs a couple more seconds for the computer, or?
You're very optimistic.
Very optimistic, okay.
One minute.
We are in Barcelona, okay. Marco?
Thank you very much. The transition to the bedside will not be immediate. I mean, we have to take a couple of steps in the lab first. Let me summarize what we just heard in terms of applied physiology. What we want to avoid is the opening and closing of the collapsed alveoli as detected by the lower inflection point, and to avoid the overdistension of the normal alveoli as detected by the upper inflection point. So it seems quite reasonable to use the static volume pressure curve to set at the bedside a safe ventilatory strategy. But there are a number of issues that limit the use of the static volume pressure curve. There are many, and Luciano will certainly comment on that. But what is most important to me is that we have to understand that the relationship between the ventilator settings and the occurrence of ventilator-induced lung injury are relating to cycling events that occurs breath by breath and are caused by the dynamic interaction between the ventilator settings that we are currently using and the actual status of the respiratory physiology. In 2000, after my sabbatical at the University of Toronto, we published this paper in anesthesiology. What we wanted to look was the use of the pressure time curve to detect the presence of ventilators-induced lung injury. During constant flow ventilation, the shape of the curve can predict the changes in respiratory compliance. If during constant flow ventilation the pressure time curve is linear, means that compliance is constant throughout tidal inflation. If the pressure time curve presents a downward concavity, means that compliance is progressively increasing during tidal ventilation. If the pressure time curve has an upward concavity, means that compliance is progressively decreasing with tidal inflation. Now, if there is a progressive increase in compliance, means that going from end expiration, from the beginning of inspiration to the end of inspiration, we have a tidal recruitment and then the recruitment of the collapsed lung. That means stress due to opening and closing. If compliance remains constant, means that I don't have either tidal recruitment nor tidal overinflation. On the other hand, if I have a decrease in compliance during tidal inflation, means that I have overdistension going from the beginning of inspiration till the end of expiration. And we randomize isolated lung to be ventilated for 3 hours with this different shape of the pressure time curve. And we use a coefficient called stress index to describe the shape of the curve. A stress index equal 1 means a straight line. A stress index lower than 1 means a downward concavity due to opening and closing stress. A stress index higher than 1 describes a curve with an upward concavity describing the potential risk for overdistension. And as you see, the relationship between the stress index and the number of markers of ventilator-induced lung injury, histology here, IL-6 here, can be described by a U-shaped relationship. When the animals were ventilated with the stress index equal 1, we had the minimum amount of stress. When the animals were ventilated with a stress index lower or higher than 1, there was an increase in the markers of ventilator-induced lung injury. And if we wanted to assess the sensitivity and specificity of this test to detect the presence of ventilator-induced lung injury, we obtain a quite high sensitivity and a reasonable specificity. We then decided to go to a more complex model of ventilator-induced lung injury. At the same time, the NIH trial was published. And so we therefore use an intact model of ventilator-induced lung injury as described in this paper presented this year at the ATS. And we used 3 groups of animal. The control was animal submitted to high source of mechanical stress, a very high tidal volume, no PEEP. And then 2 controls. The first one was the NIH ventilatory strategy to protect the lung. The second group was a stress index strategy, where tidal volume and PEEP were set to obtain a stress index equal to 1. And we look at a number of items of histology and cytokines in 2 different lung zones, the non-dependent and the dependent zone. And here is the non-dependent and the dependent lung zone in the animals ventilated with a clear injurious strategy, high tidal volume, no PEEP, and the animals ventilated with 2 protective strategies, the NIH and the stress index. As expected, both the stress index and the NIH were able to protect the lung in the non-dependent zone. But what was very interesting to us to see that in the NIH group, the non-dependent zone were affected by a sort of presence of ventilator-induced lung injury, and only in the stress index group was able to protect also the dependent zone from ventilator-induced lung injury. We look at the same strategy in a completely different perspective, and this paper is actually in press on the Journal of Thoracic Surgery. We look at the different effects of ventilation during lung transplant. And in a complex model of rat transplant, we look at the cytokines concentration in the transplanted lung ventilated with the stress index strategy or with what is called the standard ventilatory strategy for that animal model. And we found that in the lung, in the transplanted lung, ventilated with the stress index strategy, the cytokines concentration was lower than in the lung ventilated with the standard ventilation. But then we wanted to go to an even more complex model, looking at more complex physiological interaction. And this study that has been just completed and will be presented at this Congress by my friend and colleague Salvatore Grasso, looked in a pig model of ARDS using liquid lavage, if really the shape of this pressure time curve is really able to detect the presence of no stress, of the stress due to tidal recruitment, and to the stress due to tidal overdistension. The animals were ventilated first to obtain a stress index equal 1. Then they were randomized to change the shape of the curve in order to obtain a stress index lower than 1 by decreasing PEEP and increasing tidal volume up to 15 ml per kilogram, or to show overdistension that was obtained by keeping PEEP above 15 and increasing tidal volume up to 15. And here is the strategy that leads to a stress index equal to 1. We start on ZIP. We progressively increase PEEP in order to obtain a stress index equal to 1. And this is how the lung looks like at that stage. You see that there is no presence of what is called overdistension, but some area has still collapsed. Then we apply a lung recruiting maneuver. And this is the lung, how it looks like after the application of the lung recruiting maneuver, starting from a stress index equal to 1. Here the lung is completely open. The difference is that after the application of the recruiting maneuver, because of the recruitment of previously collapsed unit, the one that were described here, we had to further increase the PEEP level in order to maintain the stress index equal to 1. So this was our control. And we measured the ventilation perfusion rate using the inert gas technique to assess shunt at dead space using the technique developed in the Goran Hedestierna lab. And we combined this measurement with the assessment of tidal recruitment and de-recruitment and eventually overdistension using the CT scan as proposed by Luciano Gattinoni. And for the first time, we combine these two techniques to assess the effect of mechanical ventilation in the animal model. And here is and expiration and inspiration with a stress index lower than 1, and you have the distribution of the CT numbers. And you can see that going from end expiration to end inspiration, you have a clear tidal recruitment. So the shape of the curve, the stress index, is able to predict that during tidal inflation, I will have tidal recruitment. This is a stress index higher than 1. You can see that if you look at the CT distribution, there is a sort of potential increase on the expression of the area of overdistension. With a stress index equal 1, there is no change in the overdistension area, no change in the tidal recruitment area, suggesting the lack of mechanical stress. And if you look at the data of the total numbers of animals, here you have the stress index value, you have the tidal recruitment evaluated using the CT, you have the tidal overinflation using the window suggested by Luciano Gattinoni. But when you match this information with the information obtained by the evaluation of the VQ ratio, you can see that actually alveolar dead space is much increased when the stress index is higher than 1. What about the clinical data? Well, in order to export this information to the bedside, we had to develop a tool that is able to tell us at the bedside if the shape of the curve has a downward concavity, has an upward concavity, or a straight line. And we then could use this tool to assess the use of this strategy in patients ventilated with ARDS. And I'm glad to present you the results, the preliminary results of the first clinical trial performed by Salvatore Grasso, who sent me the data just a few days ago. And here is just the Excel file describing the results. We studied 15 patients with ARDS with different underlying disease, with a quite high Apache 2, ventilated for a quite variable numbers with ARDS. Here is the age and the gender of the patients included in the study. They were first ventilated according to the NIH protocol, and then shifted to the stress index strategy according to the algorithm that I described to you before. As you see, on average, all patients ventilated with the NIH strategy had a stress index equal 1. So the stress index in most of the patients was able to avoid mechanical stress, but in some of them, the stress index was lower than 1, indicating that despite the low tidal volume, the relatively low PEEP level, were causing some amount of opening and closing due to, as indicated by the stress index lower than 1. This was a phase 2 trial, so we wanted to know if we could safely apply at the bedside this approach. And here is the PEEP level that led to a stress index equal 1, which was ranging between 5 and 15 centimeters of water of pressure. Then here you have the number of variation that had to be implemented in order to get the stress index equal 1. And again, we go from 0 to up to 4, 5 number of steps that were required to get the stress index equal 1. Then, according to the protocol that I described you before, we apply a lung recruiting maneuver. And as you see almost systematically, with very few exceptions, the stress index after the recruiting maneuver decreased, indicating that despite the fact that the stress index was equal to 1, the application of the recruiting maneuver was able to open other collapse unit, and again, the stress index was able to detect that. Again, PEEP had to be increased, and here you have the PEEP level that was required to bring again the stress index value close to 1, the number of PEEP variation. And as you see, as indicated by the number of stop of the procedure that were required by the changing in hemodynamics or oxygenation based on a number of criteria, this procedure was quite safe and could be obtained relatively easily in all patients. So can we use it at the bedside? The problem is, it is useful at the bedside or not? Well, to answer to this question, we have actually running a crossover design trial that is performed in Bari by my friend and colleague Salvatore Grasso and in Turin by Pierpaolo Terragni, that is looking again at the crossover design, patients ventilated first for 12 hours with the NIH strategy, then shifted to the stress index strategy that again is a fixed tidal volume to 6 ml per kilogram, and the number of recruiting maneuvers and at the PEEP level able to keep the stress index equal 1. And then back to the NIH after 12 hours. And we measure the bronchoalveolar lavage and plasma cytokines level. And we have already 20 patients admitted into this study, and I hope that by the end of this year I will be able to present you the data. While Pierpaolo and Salvatore are working on that, we are having fun somewhere else. Thank you very much.